So I am thrilled to introduce Dr. Alexis Ortiz. So Dr. Alexis Ortiz, who comes to us from Stanford, seeing patients with dual diagnosis, addiction, and psychiatric issues, I believe, yes, and works in a team framework and has a lot of wonderful tools to share with us today.
Hi, everyone. I'm so happy to be here today to talk with you about psychological strategies, behavioral strategies to work with chronic pain patients for PCPs and other providers in our brief visits. So due to time constraints, I would love to be able to teach you all of these therapies in their entirety, but that's not realistic with our time today. I'll just be highlighting some tips and techniques to augment your toolbox. And as Jen mentioned, we've provided a resource list if you're interested in learning more about any of these modalities. So I wanted to begin with a case example. This is a patient that I worked with, and you can either think of this patient or one of your own patients as we're going through and thinking about how these tools might apply for you. So Serena is a 46-year-old married Caucasian female who's presenting with persistent pain, depressive symptoms, insomnia, trauma history due to childhood sexual abuse, and passive suicidal ideation in the form of thoughts of preferring to be dead. She stated multiple times in her initial visit that she is sick and tired of being in pain all of the time. She worked as a nurse in a cath lab until last year. She has 3 children under the age of 20 and struggles financially. She meets criteria for fibromyalgia, depression, opioid use disorder, insomnia, and PTSD due to childhood sexual abuse. So I know that a lot of you have had some exposure and background with motivational interviewing, so I'll just spend a few minutes on this. Motivational interviewing is a patient-centered counseling style that focuses on resolving the common problem of ambivalence about making a particular change. And in italics, I've put here some language that you can use or try out with your patients just to help get at some of these different techniques. So in motivational interviewing, when we do ask questions, we want a higher ratio of open-ended to close-ended questions so we can get more information. So for example, what can you do this week to help you instead of your pain be in the driver's seat? Also, affirmations are particularly important with this population. Oftentimes they come to us feeling a lot of stigma, either being explicitly or implicitly treated as addicts, and feeling oftentimes very depressed, very demoralized, and just worn down by this experience of dealing with chronic pain. And so it is really important for us as providers to really highlight and emphasize their strengths and resources to demonstrate the belief that we have in our patients to be able to make small changes and engage in different behaviors. So affirmations are another really important point around all of this. So for example, you're doing a great job sticking with your opioid taper. Reflections, so that's a cornerstone of motivational interviewing, really allowing us to reflect back to the patient that we understand where they're coming from to show them that they're being heard, but also for us to do some hypothesis testing. If we have an idea of what they might mean, then we can offer that as a reflection and they can confirm or disconfirm, give us more information. So reflections are when we repeat or paraphrase the patient's, especially change language is what we want to highlight. So for example, it's really important for you to find other long-term solutions to deal with pain. That's the reflection that I gave after Serena had said to me, you know, I know that I'm not going to be prescribed opioids forever. I know that this isn't a long-term solution. And so that's the piece that I really wanted to highlight in what she had said. And she agreed with the statement, and then we talked about other options for her. Also, summaries are another important piece of MI and being able to highlight what we want patients to take home from that interaction. So your top reasons for wanting to stay off opioids are... Also the rulers, you all are probably familiar with this. On a scale of 0 to 10, how important is it for you to make, and then whatever the change of interest is. Find ways to live the life you want, even if you do have pain, to quit opioids, to adhere to a pain management program, for example. We also want to make sure to ask about confidence. So in the example with Serena, she actually was a 9 in terms of importance. It was very important for her to quit opioids, but her confidence was actually only a 2. And so when I found that out, that was really useful for us to be able to target our limited time together and really focus those efforts on building up her sense of self-efficacy or confidence and being able to get off opioids. You can also do readiness to make a particular change. And then asking after each question with the ruler why, for example, a 7 and not a 2. So we want to ask it in that format to get change talk. And then you can also ask, what would help you get from a 7 to an 8? What would have to happen? A couple other MI techniques I wanted to highlight. So it's really important to emphasize autonomy, the patient's ability to have control over their own life and make particular changes. They may not be the changes that we always want them to make, but emphasizing the reality of that. Also asking permission before we provide advice. And I really found this end of session question to be useful. For example, what are you going to take away from today's session? What's the next step for you? What will help you, instead of your pain, be more in control this week? Okay, so I put in a few knowledge checks here just to keep us all awake. So which of the following is not an MI consistent strategy? A, why would it be important for you to find other ways besides medication to manage your pain? B, I have to tell you, you need to stop taking opioids now. C, you're really determined to not let pain take away the joy in your life. Or D, it sounds like your health, wanting to be a good parent, and not wanting to be dependent on medication are your primary reasons for staying off of opioids. And if you said B, you are correct. I have to tell you, you need to stop taking opioids now is not an MI consistent strategy. Okay, and so jumping in now to cognitive behavioral therapy. So this is a therapeutic intervention that really focuses on the interrelationships between thoughts, feelings, and behaviors in order to facilitate more adaptive functioning and help patients make small changes. So one tool that I like from CBT and working with pain patients that you might consider is actually going through the pain cycle and helping them identify common thoughts, feelings, and behaviors, those interrelationships in the cycle of chronic pain. And we know that psychoeducation, especially if patients are already really motivated and feeling confident, that psychoeducation can actually be in and of itself enough to get patients to engage in change. And so giving them some knowledge and awareness of this cycle. And then I'll also ask how this fits with their own experience and where they're really struggling or getting stuck. And that's helpful for us to identify initial treatment targets together. So I provided, again, in italic some language that you can use to help introduce some of these tools. And so I wanted to briefly provide a rationale and then just jump in to get patients engaging with the tool. So activity pacing is another CBT technique. For example, you might say something like, sometimes we can get into a cycle of overdoing one day and then underdoing or being wiped out the next day, which doesn't help long term. Would you be willing to try doing some consistent activity or walking to help make more steady progress? What might be the benefits of that? So incorporating a little bit of MI, getting them to argue in favor of change. And how many days would you be willing to do that? So collaborating with them about what feels realistic, giving them some control to decide how to approach this change. Also relaxation training. So again, one brief sentence about rationale. And usually I'll just say something like, extra tension in the body can actually worsen pain. So let's practice taking 3 slow breaths together, in for 4 seconds, hold, and out for 6 seconds. So you're practicing with them in the moment, the tools that you want them to be using outside in their own lives. Okay, a few more CBT techniques. One is SMART goals. So again, when patients come in feeling really demoralized, really overwhelmed, this can be a useful tool to get them focused, to help tackle some of the things that they want to engage in that might seem too daunting at first. So really making sure that it's a goal that meets the SMART acronym. Also, cognitive restructuring. So this is a technique from CBT that really focuses on identifying where there are distortions or extremes in a person's thinking that aren't serving them well, that aren't facilitating adaptive functioning. So for example, when you tell yourself that you're always going to be miserable, how does that impact your mood and behavior? What do you notice about that? What would you tell a friend in the same situation? So trying to step back and get a little bit of perspective. Behavior activation is another really well-supported tool from CBT, especially for depression. So this focuses on getting patients engaged in pleasant and meaningful activities, getting them back into their lives. So for example, it seems like you've taken a lot of enjoyable activities out of your life because of pain. That's understandable, but likely not making you feel better long term. What would you be willing to add back in this week that you enjoy? What do you miss about that activity? So again, trying to build up that motivation. Okay, so Serena states, I work better having one really productive day, even though I end up paying for it later. Which CBT technique would be most indicated? Behavior activation, activity pacing, thought stopping, or relaxation training? Oh, I heard some range there. So the correct answer is actually B, activity pacing. And the reason is we really want to break that overdoing, underdoing cycle and getting them engaged in more consistent activity on a routine basis. So just like Rachel was talking about with the pacing mountains visual and being able to actually find that place of safe and soar and more routine engagement and activity. Okay, DBT, dialectical behavior therapy. So this is a lot of the practice that I do. DBT was a technique that was originally developed for chronically suicidal and self-harming women initially. And it's a form of CBT that has been applied broadly to individuals with borderline personality disorder and who struggle with core emotion dysregulation. And if you're doing comprehensive DBT, it's a pretty intensive program. It actually involves once a week of individual therapy, a skills group once a week where they learn tools. There's also phone coaching when they're in crisis to help them apply the skills in the moment instead of engaging in problem behaviors like suicide attempts or self-harming or using substances. And then the last component is actually what's sometimes referred to as therapy for the therapist. So having a weekly consultation team to get people into treatment fidelity and also problem solving for some of these really complex cases. And I've found these techniques to be really helpful for working with chronic pain patients. The one that I would like to introduce first is validation. So validation is finding the kernel of truth in another person's perspective or situation, or verifying the facts of a situation. So it's acknowledging that something about their experience is understandable, whether it's the facts, their own opinions, feelings, beliefs, their suffering, or their difficulties. And validation has actually been shown to help downregulate emotions. And I'll talk briefly about a research study that supported that. It's been shown to reduce that fight or flight response and that activation in the amygdala. When people are feeling validated, they're feeling more understood. They don't have to put in as much effort to kind of proving that they're right or really trying to convey that understanding to the provider. They're already being heard, they're already being seen. And so you can focus on problem solving and some of these other pieces. But I really want to highlight that validation does not mean agreement or reinforcement. So for example, I can validate that behavior activation can be challenging to engage in and still not agree with my patient sitting on the couch for months at a time. So we don't want to validate the invalid. So really being careful and strategic about what we're validating. We could also validate the function of the behavior. So like Rachel talked about, that relief-seeking function. that makes patients, for example, engage in substance use and makes that so salient in the moment, or trying to avoid pain or get out of that experience. We can validate the desire or pursuing that, but then also not validate how they're going about that, and really suggest other ways to get that need met. So when patients don't feel validated, they tend to exhibit higher levels of anger, agitation, defensiveness, not returning to treatment, not engaging in treatment. Motivational interviewing also builds on this concept that reflections and other tools from MI actually are validating to the patient, and therefore facilitating more of these kinds of characteristics. Okay, so I just wanted to highlight briefly. So this study was interesting. They actually found that in this particular study, they taught the partners of individuals with chronic pain how to validate. And then they found that when they gave them that validation training, the partners were then more validating to the chronic pain patients. And because of that, it actually reduced negative affect in the chronic pain patients. So their pain was the same, the change was in the relationship and the way of interacting with the patient with chronic pain that actually improved engagement and decreased that negative emotion. So if we want the potential for less grouchy pain patients, try some validation. And in terms of languaging this, I wanted to offer other ideas around this because it can be tricky. So the patient might say something like, I just need pain meds, that's the only thing that helps. And the provider could say something like, I know you want help managing this pain and I want to support you in that. We don't offer opioids, here's what we do offer. Have you tried X before, whatever intervention you'd like to suggest to them? Another example, the patient might say something like, you don't get it, I've been through all this stuff before, I'm just exhausted. The provider could say something like, it makes sense that you feel exhausted given that you've been in pain for so long, and yet you're here today. I see that there's a part of you that wants to find another way to manage this pain. Patient might also say something like, doctors keep telling me to just meditate, that's not going to make my pain go away. Provider could say something like, you're feeling like those things won't make any difference. I understand that. At the same time, I can tell you many patients find them helpful. I can recommend some apps, books, or programs so you can check it out for yourself. Which would you prefer? So again, giving them that menu of options. Another DBT tool is the STOP technique. So this is actually a way to teach patients how to engage in mindfulness in a brief practice, and you can also do this in the moment with patients in your sessions. So the S in STOP is also stop. The T is take a step back or take a breath. The O is observe. So using the 5 senses, we're getting them to slow down, to acknowledge that the pain is there, and then also notice what else is present besides the pain. And the P is proceed mindfully. So the function of this technique is actually to quiet the amygdala, the limbic system, and actually get the prefrontal cortex back online, to really slow down that process and allow that to re-engage. So for the proceed mindfully, you could ask them to think about what their goal or desired outcome is, their top reasons why they want to stay off of opioids, which oftentimes in the moment, those reasons can go out the window. So we're trying to remind them of their goal, to think long term, not just from that fight or flight place of being really reactive and impulsive and seeking gratification in the moment that's going to hurt their goals long term. Also asking what would make things better or worse that's in my control right now. So small things that they can focus on. A lot of my patients, when I teach this, will talk about, who are engaged in recovery communities, will talk about this idea of doing the next right thing. So that can be another way of languaging the proceed mindfully. And then we actually want to practice with patients, again, in the moment. So oftentimes I'll say something like, okay, let's try this together. Let's stop, take 3 breaths. What do you notice in and outside of your body right now? What can you do for yourself in this moment? Radical acceptance, another DBT tool. So the radical in radical acceptance doesn't mean on the fringe. Radical, it means complete or total. And the idea behind this skill, radical acceptance, is not something that we do once and then we're done. It's actually a process and something that we do over and over again. So you can think about this as a way to plant the seed of radical acceptance, and some language around that. So you might say something like, sometimes we can't keep painful events and experiences from coming our way. We can't always control what happens to us, but we can choose how we respond. We can fight against reality, and then that's where our time and energy will go. Or we can decide to try and work with what's happening right now. And sometimes I'll give the example of if someone has had to radically accept something before, for example, losing a loved one. It wasn't something where they woke up one day and it was fine. It was actually that digestion process of kind of it hitting them that that was the reality, that that person was no longer present. And then later that would happen again and again. And then over time, eventually, there would be that moment of truly accepting, of not wanting or liking, which is a very important piece of radical acceptance. So radical acceptance means completely accepting the reality that we are in pain at this moment, for example. It does not mean wanting or liking the pain. We can radically accept things that we would have never asked for, and that's the wanting or liking is completely separate. What it is acknowledging that life can be worth living even with painful events in it. So for example, you might ask about what is within your control to change. For example, engaging in a certain behavior or their narrative, the stories that they have around how this event is affecting them. So if you've heard of, there's this field called post-traumatic growth, and actually how after a trauma, when patients engage in things like meaning making, that there's ways that patients can not just survive, but actually thrive after that trauma. If there's a way that that helps them become even stronger than before, or get in touch with something that deeper that they wouldn't have known otherwise that turns out to be really valuable for them. For example, for some patients it can be their faith, or sometimes, you know, an accident or a diagnosis can lead them in the direction of a new career or something that they feel like they wouldn't have come to or found without that trauma. So it's a way of making meaning of the event, of giving value. You could also ask, what would be helpful to bring acceptance to in your life? For example, the fact that we will be in pain at some point. How can we work with that? How can we allow some space for that reality? It's also really important to, when practicing radical acceptance, to not, there needs to be empathy and compassion around the tone, because otherwise it can come off as dismissive. It can be one of those things that's like, well, it is what it is, just deal with it. We don't want that. So there needs to be empathy when we're introducing this skill. And some tools from acceptance and commitment therapy. So acceptance and commitment therapy, or ACT, is something that actually has an intervention that has a lot of support now for chronic pain patients. And this is a psychological intervention that incorporates mindfulness techniques and behavior change strategies. It uses metaphors and lots of experiential exercises to help patients identify what's really important to them with their values and take steps to move in that direction regardless of the thoughts or feelings that come up. So it helps them to get into healthier contact with thoughts, emotions, sensations like pain that have been feared or avoided. One of the primary metaphors or experiential exercises in ACT is this tug-of-war metaphor. So really trying to get patients to realize if they're struggling against the reality of something that they're not going to win that battle and it's not helping them. So for example, if they're really in resistance or struggle around getting a diagnosis, you know, I can't believe this happened, it shouldn't be this way, it's not fair. And if that's where all their time and energy is going, trying to work with them to highlight, you know, is that what you really want for your life? Because that's where your time and energy is going, into fighting this. Is it working for you? Is it serving you? What are you missing out on or losing by your time and energy going towards that? And really trying to then get them back in touch with what's really important to them, their values, and highlighting those pieces that are really missing because they've been caught in this tug of war. So this is what's known as the ACT hexaflex. So these 6 different components. So what you could do in your intervention with patients is just focusing on one or more of these pieces. So for example, trying to get at values, and some of Rachel's handouts are really helpful for that, getting at what's really important for them. So for example, with Serena, it was really important for her to be a good parent. That's one of her top values. And so after we highlighted that, we then looked at commitment and actions that she was willing to take, even while being in pain. So she said, okay, it's really important for me to be a good parent, and something that I could do concretely would be I could go to my kids' basketball games, even when I'm in pain that day. So that would be something, because one way of getting at this is sometimes asking, if I were following you around with a video camera, what would I see you doing? So we want to get at observable actions that they can take that would allow them to move towards their values. Because we don't want them to just think differently about that we want them to actually engage in their life differently. So sometimes people will say with ACT is about living life from the feet up, not the head down. Also, self is context, being able to realize that we are not just our thoughts, we are not just our emotions, we are not just our pain, we're actually much larger than that, and getting some observer self around that experience. Also being present, so that's another component of mindfulness, as well as diffusion. So there's a lot of ACT techniques that help us just get a little bit of distance, ability to step back from these stories, because oftentimes patients will come in so fused with these stories that are not serving them around, I'm always going to be in pain, and their lives get really, really small. Or, my life is about nothing but pain. There's nothing else. I have no other joy. And getting them to kind of broaden that perspective and see what they might be leaving out of that bigger picture. And finally, acceptance. So this is the willingness to experience difficult thoughts, emotions, and sensations. So for example, again, that sore and safe zone, actually some willingness to kind of get into that and stay in that zone where they can engage in their lives even with some pain. Because oftentimes patients come in so unwilling to experience any pain because there's been such a fear conditioning around that. So again, ACT is less about making the pain go away and more about getting disentangled from thoughts and feelings, getting patients moving in a direction that's really important to them. So as providers, we can try and figure out where is their focus and their effort going. Is their life about trying not to feel pain or about building a rich and full and meaningful life? You might notice what thoughts or stories they're fused with that are really driving the bus, that have kind of full control, and they can't get any separation from those beliefs. So you might ask, what has pain been keeping you from doing that's important to you? How would your life look different if you were more focused on what mattered to you instead of trying to feel less pain? Okay, so our last knowledge check. What would not be an ACT consistent message to communicate to Serena? Let's concentrate on getting rid of this pain. I hear that you want the pain to go away. If you didn't have pain, what would look different for you? What do you care about? Would you be willing to have some pain in the service of pursuing the things that are important to you? And if you guessed A, you are correct. Let's concentrate on getting rid of this pain is not an ACT consistent message. Okay, so I wanted to make sure we also talked about not just tools for our patients, but tools for ourselves. So thinking about this idea of who heals the healer. And depending on how we look at this question, this answer can be either no one or we do. And I'm still trying to work on radically accepting that this is the case, because it is challenging having so much of our energy and efforts go outwards to helping others. And then at the end of the day, we're still responsible for our own self-care and making sure that we're capable of doing this work. But it is really important. You can check into your own experience to recognize that, that idea of you can't pour from an empty cup. So these are some strategies to try and replenish or refill the cup, so that we have resources to be able to offer. So for example, you can think about how often you're consulting and getting support from other providers, maybe creative ways to incorporate, a monthly lunchtime consultation, if that's not already available to you. Also, the way that you're consulting or getting support. So we found that on our DBT team, that it's really helpful when we're presenting our consultation question, not just to present the question, but also to be really clear about what we need. So sometimes we want problem solving, we want ideas, we want advice, and sometimes we just want validation, we just want someone to listen. And so getting really clear, or sometimes we're really struggling with having empathy for the patient. And so really being clear so that others can better meet our needs about what those are. Also, fortunately, the mindfulness tools that work for our patients also work for us. There's a huge body of research now that supports the use of mindfulness in terms of increasing well-being, decreasing burnout, better sleep quality, more vitality and energy and engagement in our work. And so things that you might consider, and these are things that I've incorporated that have been really helpful just in my own clinical practice. So actually using the stop skill before or after seeing patients, even if it's just for a few breaths, a few moments, taking a breath when you walk through a doorway, that's now an automatic mindfulness practice that I have. Every time I walk through a doorway, I take a breath. And that can be helpful also when going in to see patients and leaving. Digital detox and technology hiatus. So there's a lot of support also now for the health benefits, especially mental health benefits of disconnecting from technology and having those periods of time to just reflect and rejuvenate. So thinking creatively about how you might be able to get that. Also celebrating small victories. So I actually want to practice this in the moment if you're willing. To write down 3 things that have gone well with your patients or patient care recently. These can be outcomes with patients, or they can just be your approach or attitude with patients. So we'll take a minute to do that, if you're willing, just writing down 3 things that have gone well recently. Not perfect, but okay. And you don't have to share these with anyone, but you can if you like. So something that we've done in our weekly consultation team is actually added a column when we're going through our agenda. So we have administrative issues, we have new patients, patient updates, safety concerns, and then positives. And so we actually have incorporated this into our weekly consultation team, where everyone gets a chance to just, if you have one, just share that. And it really has increased the morale and decreased the burnout. We've definitely felt that shift in the team since we've been implementing that as a way to just celebrate small victories. And reconnecting with values and purpose. So how is doing this work consistent with what you value in life, what's important to you, why you got into this work in the first place? So this might be around alleviating suffering. This might be making a contribution or caring for others, maybe leaving a legacy that you feel proud of. So taking some time also to reflect on that, the values piece around this, especially before we ask patients to do our own work. There's that idea that it's hard to lead where we haven't gone. And so doing this on ourselves can actually facilitate teaching this to patients. Okay, I wanted to say a little bit more about reconnecting with empathy, because we know this is so important. We know that providers who feel more empathetic actually have lower burnout and deliver higher quality of patient care. And among other really positive outcomes, there's more and more research to support this. So really trying to think about how we can get back in touch with this, because our work can be so challenging and so draining, and we can lose connection with this. So one way of doing that is actually trying to think about the patient's perspectives, experiences that they might be having coming in. Another thing that I will do sometimes is just, if I'm really struggling, is to think to myself that the person who is sitting in front of me is someone who is really suffering. And they're trying to get their needs met the best way they know how, which might be terribly ineffective and really challenging for us, but might also be the best that they can do in this moment. I'll also sometimes remind myself of the distinction between primary emotions and secondary emotions. So primary emotions are our emotions about a situation or circumstance, and secondary emotions are our emotions about our emotions. So a common primary emotion can be sadness, and a common secondary emotion or reaction to the sadness can be shame or anger. And so a lot of times when patients are coming in anger, I can just remind myself, okay, they don't know how to work with the sadness, it's too painful. Because if they got to the sadness and that hurt, I could be much more compassionate with them. But they're coming in anger in that secondary emotion because they might not know how to actually get to the primary emotion, to the hurt that we know is there. So this is them doing the best that they can. And so sometimes that actually is really effective for me to get back to a place of empathy with the patient. Okay, a few take-home points. So using your resources, we provided a number of those today. Referring to behavioral health, if available, we really want to help you. And so if that's available, and validating patients and our own suffering and struggle. So giving ourselves some of that empathy, that compassion is really important for being able to continue to do this work long term. Also, MI really helps with this, but this focus on empowering the patient. So at every chance, I will try and shift that problem-solving onus back onto the patient. So, for example, asking, why is it important for you to make these changes? What do you want to look different in your life? What would help you with that? So that we can be both collaborating and engaged in this process instead of, us having to do all of the work and then being the passive recipient of that. Also remembering the power of and evidence for positive reinforcement, making these small changes and planting these seeds, and really helping to strengthen our belief and expressing that to patients that they can make these changes. Again, they're coming in oftentimes so beaten down and so demoralized and really struggling from being in pain for so long, as well as other stressors that they might have experienced. So really focusing on those small changes and highlighting, reinforcing those. And then what you're already doing today, CMEs and getting additional training in some of these techniques if you feel like they would be helpful for your own practice. So I just wanted to close with this quote from Dr. Seuss. He gives us a nice motto for this empowerment mindset that we're working to facilitate in our patients. You have brains in your head, you have feet in your shoes, you can steer yourself in any direction you choose. Thank you.